Again, let's see. Here are my disclosures. Okay, so quick question at the beginning. This is your pre-test. Which is the ideal patient for FXR-based therapy, stage 2, stage 3, stage 4, or histologically active NASH regardless of fibrosis stage? Oh, okay. Well, let's see what the data tells us. So the first thing, FXR is the cognate receptor for bile acids. And so I know that unless you're a bile acid aficionado, many people don't normally think about bile acids in their everyday work. So bile acids were discovered by Henrik Wieland and got the Nobel Prize for that in 1927. And really, these are derivatives of cholesterol. And the only way the body can get rid of excess cholesterol is either to secrete it in bile or convert the cholesterol into bile acids. And this happens in the hepatocyte through two pathways, one in the cytosol, one in the mitochondria. And they result in two different bile acids called cholic acid and chenodeoxycholic acid, which are called primary bile acids. These primary bile acids come out in the bile, and they form micelles. And these micelles then allow to solubilize the cholesterol in the bile. And when they go into the intestine, they are converted by the bacteria in the intestine that take off hydroxyl groups from these molecules. And cholic acid is converted into deoxycholic acid, and chenodeoxy is converted into lithocholic acid. And these are very hydrophobic molecules and cytotoxic. So deoxycholic acid has been linked to a variety of cancers, and lithocholic acid is also very cytotoxic. So a tremendous amount of biology has now been described with respect to how these bile acids actually work. So when I was going to medical school, I was taught that the role of bile acids is to dissolve fat and to allow us to digest fat. But turns out every time you eat, you have enterohepatic circulation. These bile acids are reabsorbed in the ileum and they circulate back to the liver. And during this process, they provide information to cells, not only in the liver, but elsewhere in the body, that nutrition is coming, because every time you eat, you have enterohepatic circulation of bile acids. And they're very important sensors of nutrient availability and allow the body to readjust its metabolic machinery based on availability of nutrients. So in the intestine, bile acids can bind to what's called TGR5 and also to FXR. And by binding to these FXR receptors, it releases from the intestine something called FGF19, which feeds back on the liver and has very similar biological properties as bile acids and FXR agonists themselves. So bile acids, when they work on FXR in the intestine, they are basically forces the intestine to clear the hepatocyte of bile acid. So it either will shut down production of bile acids or it will move bile acids into the bile. Now, cholesterol is turned into bile acid. So if you shut down production of bile acid, your cholesterol level will go up. So that's the basic biology. Now, we have actually published extensively the pharmacology of obeticholic acid, which is the prototypic FXR and the first generation FXR agonist. And what you see over here is sort of a radar plot where in the center, in the dotted lines, is what the activity for gluconeogenesis, inflammation, fatty acid synthesis, fibrosis, TGF-beta signaling, and bile acids is supposed to be. And in the solid line is what it is in NASH, and what you're seeing in the red line is the shrinkage, how you are bringing it back towards normal. And so it reduces the lipotoxic stress, and the inflammatory fibrogenic signaling in response to that. So jumping from here, knowing that it can actually affect lipogenesis, it can affect inflammation, it can affect fibrosis, that provides the rationale for studying it. And I will leapfrog over all the early phase studies like the Flint trial, et cetera, that were done to the Regenerate trial that we published a couple of years ago. And this is a phase 3 and the largest NASH treatment program currently worldwide. So it's a 3-arm study, placebo, 10 milligrams and 25 milligrams of obeticholic acid. And you get a biopsy at the beginning. And the way the drug approval system works in the United States is they follow what is called a conditional approval pathway, where for drugs that have, for diseases that have great unmet need, there is no other drug out there, they will allow approval based on surrogate markers with the idea that you will continue the study and show that the surrogate marker improvement translates into actual clinical outcomes improvement. So at month 18 is the interim time point for that surrogate marker analysis by histology. And there are 2 endpoints, fibrosis improvement by 1 stage or more without worsening of NASH, or NASH resolution without worsening of fibrosis. So, or not and, either one will give you conditional approval. It's not a full approval. It just says there's a huge unmet need. We have reasonable evidence that it sort of is working, but keep going on with the study, but the drug is now approved. So over time, there were 2 types of analysis done. The original analysis, there were 2 pathologists who read all the biopsies. But what has happened during the course of the last 2-3 years is that the best practices in terms of how NASH histology is to be reviewed in a clinical trial has evolved. So the current guidance from the FDA is that you have to have 3 pathologists. And at the very least, they have to read the biopsy independently and agree on all of the features. If they disagree on even one, that's a non-responder. So then they, of the 3, 2 have to agree on all 4. And then if the 2 don't agree on all 4, then the 3rd one is brought in, and then at least 2 of the 3 have to agree on all 4. And if they don't, that's a very conservative approach to reading the biopsy. So the data for the original analysis shown on the left, new analysis shown on the right, and basically you land in this pretty much the same place, that there is improvement in fibrosis without worsening of any of the NAS components, which is steatosis, lobular inflammation, and ballooning. And those with F3 seem to have a little bit better response than those with F2. So remember, F3 is where the natural history, you already have a big jump in liver-related outcomes. Yet the disease can still be turned around. So F3 is in many ways the sweet spot for treatment of NASH from a liver perspective, because we have not quite, the F4 is ideal if you can, but that's a very high bar. We have not achieved that yet. And so if you look at basically the entire population, which also includes people who have stage 1 disease, you can see over here that actually there's a very high response rate. So on all stages up to stage 3, good anti-fibrotic response. And whereas in placebo, you are seeing over time that it's relatively flat. If you look at the treatment arm, you're seeing a greater proportion of people who are improving their liver histology. Now, OCA has a number of side effects, and this is why 2 years ago the FDA said, no, we're not willing to give you conditional approval, because approval in the end is the analysis of benefit and risk, not just meeting an endpoint. And so they said, keep going. So we now have over 8,000 total patient years of exposure, and 1,000 patients have received the drug for over 4 years. It is the largest safety NASH database to date. And as you can see, it is a relatively balanced treatment emergent adverse events. And of course, the most common one is pruritus, which is, as you might expect, higher in patients on OCA. There are several adverse events which are considered adverse events of special interest. And there is a signal for gallbladder disease with high-dose OCA, because OCA reduces remember, it is suppressing bile acid synthesis. So there's less bile acid coming out in the bile, so cholesterol saturation goes up, and you get gallstones. So you can actually get cholecystitis. There was a signal for pancreatitis initially, but it's completely flat. There was an initial signal that the glycemia might go up a little bit. That's completely flat. And similarly for urolithiasis. From a liver safety point, there are occasional patients who had some liver enzyme elevation, but it was almost all mild, with a couple of exceptions, with a few exceptions that were considered potentially more serious, and one patient who actually ended up getting a liver transplant. Cardiovascular safety actually turns out that the increase in cholesterol, it tends to drift down over time and is quite manageable with statins. And the core MACE, 4-point MACE, and 5-point MACE are all relatively flat. So there is no evidence that you're having more cardiac events with this. Very interesting, when you give the LDL cholesterol, when you give this drug, the LDL cholesterol goes up within 1 month, but by the time you come out to 48 months, even in those who did not get statins, it drifts back down to baseline. And certainly those who get statins have very rapidly, their cholesterol comes down to baseline or even below baseline. There was some AKI question in the beginning, but it's absolutely, as you can see, the number of patients with AKI are similar to placebo. Now, the reverse study is a cirrhosis trial, which also looked at 10, 25 milligrams versus placebo. And unfortunately, the top-line results was negative. It did not provide histological benefit. So where we've landed now is that there is a biological rationale from preclinical studies suggesting improvement in lipogenesis, inflammation, fibrosis, gut permeability, and microbiome. The OCA actually has been shown to reduce fibrosis, and Regenerate is an ongoing trial for clinical outcomes. And there are other FXR molecules that are being developed, but they all have the similar tolerability issues. So I'm going to stop there because I know there's other case-based discussions coming. Thank you.